We're going to begin this evening's event with a presentation from a panel of community experts. Marcus Cheatham, the health officer from Mid-Michigan District Health Department. We have Dr. Rebecca Cunningham, who is Associate Chair for Research and Professor of Department of Emergency Medicine at the University of Michigan, and Healthy Flint Research Coordinating Center. We have Dr. Greg Forsley, who is the Chief Medical Information Officer for Trinity Health. And we have Cynthia Green-Edwards, who is the Director for the Support Services and Business of Integration, Michigan Department of Health and Human Services. And I want to thank Cynthia especially because she found out probably about 3 minutes ago that she was going to fill in for Sue Moran, who unfortunately had a family emergency. So thank you, Cynthia. And finally, I want to introduce Dr. Deanna Hedgebegovic, who will sort of kick off this event for us. She is the program analyst at the Office of the Assistant Secretary for Preparedness and Response from the Department of Health and Human Services.
Thank you so much. I was told that this will work. I don't know if you can hear me. Can you hear me? Oh,
there we go.
Great. I also find out about this event 2 days ago, and half an hour ago I was told that I was asked that, to kind of moderate this session. And actually 2 days ago, when they told me that I need to come over here, I was asked myself, well, why I should come over here, because IT, health, data, I don't know much about IT and health. I know that I need it, and we need it. But then I start making some connections. A week ago, I was actually working with the Flint responders from HHS. I know maybe most of you know that HHS, Health and Human Services, is a designated agency to respond to water crisis in Flint. So I was part of a team that went almost in January and tried to answer some questions that state had at the time, and was part of human service task force. That was several issues that my colleague and myself tried to kind of connect different government agencies and state and communities. So, and after that, I went a week ago to the Department of State, Michigan Health and Human Services, and it was a session about recovery, how to do recovery in Flint. And I prepared big presentations. I said, okay, I have this presentation, I have that presentation. I can tell you what is National Disaster Recovery Framework. I can tell you all about recovery support function, health and social services. They told me, no, we don't want to hear that. We know all about that. And I was kind of, shaking when I get there. I don't know what I'm going to be asked. And my boss and I went there because I was kind of feel safer with my boss next to me. If I say something wrong, so she's there, she can pull me out. So, but it actually went very well. It was really good conversation. And I asked, okay, what do you need to know? They said, okay, tell me how we're going to do recovery, what we need to do, how we're going to make a plan to be the plan that we can use for this Flint crisis, and also that the plan that can be used for any other disaster, a little modified, but it could be used for other disasters. And that's how our conversation started. So I was asking about health recovery coordinator. I was asking about community involvement. Do they have all needs that community has listed up? they are connected with the community recovery group, different NGOs. So how about different government agencies? How about leveraging existing programs? How about different task group, like human service task group, that human service task group will cover human service issues? How about children and youth task force? How about mental health, big issue, mental health task force? And that kind of started, those information and questions kind of pushed them to think. And they said, that's great. This is what we need. And then they put the list together and they said, okay, did we forget anything? Yes. Maybe we should also think about IOM report, medical report that on recovery and how address recovery issues. There are like 12 suggestions, 12 recommendations from that IOM report. And one of those recommendations is connect to having data available and connect to IT, so you can follow those people, in this case children, that are down the road, may not have some issues. And that happened also, I'm digressing a little bit, that happened also in Sandy. So in Katrina as well, for example, so many people were displaced. And how are you going to find those people? How are you going to, when you put those people in different housing, how are you going to have them access to health and health services? So all that needs data, all that needs some kind of tracking. Also, I love using health in all policies. Again, you need data for transportation, for housing, for economic, because all that is kind of connected. When I say health in all policies, this came out in 2010. WHO actually came up with a recommendation that we should all, internationally, and United States also accepted that, we should use health in all policy. For example, very simple, if it's a disaster, you staying home with your kids. If you cannot, it's, let's say, maybe a month after disaster, you need to go to work. How are you going to go to work if you don't have a place to put your kids when you're working? So you need childcare available. Also, that's what I'm talking. It's connected with the economy. It's connected with housing. It's connected with transportation. And that's why we need to think about health in all policies. So when I was thinking about that work that I have previously and why I am invited to this session, I said, okay, now it makes sense. So that was a little bit about my kind of role here. And they told me that I supposed to moderate this. I will try my best, but I think we should all actually kind of participate in discussion and in those list of, there are some questions here, but we can have this conversation ongoing because it's about you. It's not about me. It's not about government. It's about community. It's about you. And that's why we all need to discuss. And we actually need to hear you. What do you think about different issues? So I will let other colleagues to introduce themselves and say why you are here and how we can kind of support this conversation, how we're going to answer those questions all together.
Great. I have a microphone. Thank you.
Okay.
Yep. Good evening. I'm Greg Forsley. I'm a family physician who moved into informatics about 15 years ago. I've been involved in the state informatics development in terms of health information exchange, health information technology, by being on the commission as well as, excuse me, now 2 health information exchange boards, both Great Lakes Connect and now recently to the MiHIN board. And I think the important thing, my role at Trinity Health blends right into this. 4 years ago, I left my role as Chief Medical Information Officer at St. Mary's in Grand Rapids and went to Livonia to the System Office for Trinity Health. And for those of you that don't know, Trinity is in 21 states across the United States. We have a very robust exchange of data and information and are trying to build an infrastructure to support a lot of things Diana just talked about. What I'm focused on is our employed network, but more recently now into the risk models and supporting population health technology that will allow us to do probably not the full social gamut that you talked about, but at least starting a little smaller with trying to share health information, data, that turn that into information to identify those folks that you heard about all day today that are at risk for becoming a very expensive healthcare situation in the near future. Those people that have already, as the words were used, fallen off the cliff, how to make sure that they don't do that again, to make sure that they get connected into the proper systems. And so we have a risk model situation in all of our regions that are set up across the United States that is now trying to learn from that, as well as to experiment with very different types of deployment and implementation models using our core system of employed physicians as a center, but then recognizing the critical importance of the other healthcare providers in the community, so the affiliated physicians, the long-term care that are part of our network and also not part of our network, as well as home health being a very important and critical kind of keep people in place as things go forward. So with that, I'll turn it over to Mark.
Marcus Cheatham. I'm the health officer of the Mid-Michigan District Health Department. So I represent local public health. I'm looking at about 200 people who know more than I do about information technology. We are an electronic, a local health department. We have electronic health records. We use all of the big state systems, surveillance, immunizations, things like that. So I can talk a lot about the experience of information technology at the local level. But I just want you to know, I spend more time talking to people about why they need their septic tank pumped, or why we need to inspect their restaurant, or arguing with a mom who wants a waiver and doesn't want to immunize her kids. That's how I spend most of my time. What I know about federal policy-related information technology is because I am the co-chair representing the National Association of County and City Health Officials, on the Joint Public Health Informatics Task Force. So about 2 times a year I make a trip to Washington and we talk about all things federal IT policy. I have been involved in informatics since I started my career. About 12 years ago, I was at a meeting at the Lansing Chamber of Commerce just across the street here, where we had a number of local health departments, hospital partners, folks like that who knew this thing called information technology was coming. And but when we were wondering, what do we need to do to get ready for this? So we invited Jim Collins from the state surveillance system, Bob Swanson from immunizations, and a few other people. And they came into the room and said, "We've been waiting for you to call." And we were like, "What?" And they said, "Well, we've been working with the Public Health Informatics Institute, getting ready to have our data systems be interoperable." And many of you know the Public Health Informatics Institute is one of the most influential organizations in public health IT. And so the state has had a partnership going for a long time to get ready for this. So when we look at things that we're doing now, Great Lakes Health Connect, my staff use that in their work all the time, getting ready to try to pilot electronic case reporting, man, we've come a long way. We have accomplished a lot in what is actually a relatively short period of time. And I think we in Michigan, we have a lot to be proud of.
I'm Rebecca Cunningham. I'm an emergency physician by training, and I wear a couple different hats. One, I direct one of our 9 regional CDC centers on injury prevention and control, and think a lot about in my daily life about injury prevention, including opioid and the prescription drug overdose and surveillance of that, both in Michigan and regionally. Most recently, I'm one of the founding members of the Healthy Flint Research Coordinating Center, which is an academic community-led partnership focused on joining the needs of the community around both data and research, as well as informing what the next steps are around the water crisis in Flint from an academic perspective. So I've spent about 20 years doing longitudinal research in Flint, Michigan. I was a physician at Hurley Hospital for many years. and have an ongoing portfolio there. Our current work involves trying to connect the data needs, which are many for both public health as well as for community members, what the many data sources are for Flint, Michigan right now, what the needs are to share those between health professionals, community members for ongoing behavioral health and physical health. Spent some years tracking populations longitudinally and understanding both from a health system and a population health component. And then in my personal practice, have watched the evolution of information technology and the possibility of our ability to share that information more broadly for public health.
And I think this is all about emergency preparedness that I'm being tested for here. So
test.
I'm sorry that it's not Sue Moran, but I am Cynthia Green-Edwards, and I'm not a physician, but I am a nurse. And as a nurse many years ago, I helped to implement an order entry system and had no idea that that would transform to an electronic health record as it is today and what we're doing. So it is very interesting. I'm with the Business Integration Center, which is a newly established area within the Department of Health and Human Services. However, throughout the 20 years that I've worked for the state, I've worked across the two different departments quite a bit. I was in Medicaid, but I worked with public health a lot. I was responsible for health information exchange within the state. I'm a board member of the MiHIN, and I've been responsible for trying to get the data to where it needs to be. I have also been responsible for the data warehouse for the department, and I always hate to say this, but I'm also the security officer for the department, so that usually sort of, is an issue. But, we do share, and I think that's the most important thing, is that, a lot of people think that you can't, and I've worked a lot, and it's all about sales and marketing, I have to tell you, with the other departments and to try to get them to share their data. And over the number of years, every time people think that if they put their information in to the data warehouse, that means it's available to everybody, and we've had to prove to them that we can protect this. And at one of the MiHIN board meetings, I know I gave a presentation about all of the great things that we're doing, and we did have a citizen that was there and asked the question, how can you guarantee that this information, my information, is being protected? And I gave her the explanation of how we're doing that, and at the end of that board meeting, she came up to me and she shook my hand and she said, thank you. And that was the most gratifying situation that I've been in, because that could have been really bad for everything that we're doing here if she didn't trust us that we were going to protect the data. So as you're talking about what you're trying to do and all your analytics and so forth, we're trying to get the information there, but also make sure that it is protected and it's only available for those who need to see that information.
Thank you everyone for introduction, and I have a list of some questions here. And for example, if we look on Flint, New Jersey, and other communities that are similar to those who actually suffer disasters, urban, rural, and increasing threats of natural disaster, and having in mind that disaster changed, and every disaster is, no matter how prepared and planned we are for disaster, every disaster will be, in the end of the day, new for us. What are the unique opportunities that community might leverage to, for example, help educate the community about environmental public health? What about vulnerable population? What are the needs to develop evidence-based guidance for all phases of coordination across state and local health and human services, including behavioral health, public health, population health, and clinical services? So thinking about addressing that preparedness and disaster, we need to basically identify cross-cutting issues. We need to make sure that health priorities are included in community discussion and vision. So we need to make sure that infrastructure that prioritize restoration and essential to continuity of healthcare services. Also, we need to think of permanent housing, health hazard, access to healthcare, low-income individuals, at-risk population, and collaboration and communication. Not forget people who are not English speaker people, not forget disability, people with disability and access and functional needs. One word, at-risk population. So what do you think about how this is all connected? And we can start from you, and then I think audience can also respond.
I'm happy to jump in. I don't think I can address all of those, but when I think about the importance of community responsiveness, I don't think we always leverage what we already have. So Michigan has an emergency preparedness regional system set up that we need to expand upon and leverage to think more broadly. But it really comes down to appropriate information, effective communication, and inclusion. And what I mean by that is making sure that all the right people that we've identified need to be a part of the solution to any disaster that occurs, making sure that the information feeds bring not the fire hose of data that we've seen today, but the relevant information, whether it's at a community level or even down to the individual level. You mentioned Katrina. One of the big lessons learned there was one hospital system in that region that was electronic, Our Lady of the Lakes, and that hospital became the respite for all of those people that were trapped in the Super Bowl and the others for any information that was relevant to them regarding what medications they were on or any of the other disaster things that happened. So somehow we want to build a repository, but also, as Cynthia just pointed out, make sure that it's protected and private and used only appropriately.
Yeah, I think part of it too is you don't wait for the disaster to happen.
Right.
You know, we really have to push and, you know, get people connected, get them utilizing it, because then you've already bypassed all those barriers right there. They've got the information, and then they've been using that they're prepared and they know what the population looks like, they know what they need to do early on, and not wait for that disaster to happen.
So I would like to bring a local perspective on this, and you and I talked about this before the meeting. Local public health is a first responder, so we're very much involved in creating emergency preparedness plans and talking to emergency managers and, you know, people who will coordinate disaster response at the local level. And as a local public health officer, I have a serious concern that we aren't ready for disasters. And the main issue for me seems to be all of the plans that we spend hundreds of hours writing. And so someone at FEMA can check a box. The Mid-Michigan District Health Department turned in their plan. But the time we don't spend practicing, drilling,
Yes.
you know, my nurses have to practice going out into the field with the cops to, you know, deal with disaster victims. They have to practice that. And we don't get nearly enough of that activity. So I think that's really important. And I think information technology is part of that, because you have to know how to use those systems that you will use in an emergency. When you sit down in your strategic national stockpile software and you call it up and it's the first time in 6 months that you've looked at it, you're not going to get your drugs on time, you know. So.
I also think that is very important, that not only having a plan and think about and exercise, because as I mentioned before, disaster change, and we're going to have more and more disaster that we don't have ticket to money, meaning Stafford Act. Like Flint, there was emergency declaration, but it wasn't Stafford Act declaration. And what we needed to do, we needed to think and communicate and collaborate to leverage existing programs. So now we have 1115 waiver in place, which you are a better person to talk about that than me. So HRSA, HHS agency, Health Resource and Service Administration, that's the name, full name. We were reaching out to them, and they actually awarded 2 big grants to health systems in Flint. So because of that, they were able to hire some people so they can do testing, they can do mental health, and they can, but how are we going to track that? Where are the data? How are we going to, evaluate what we are doing? So that's very, very important. And yeah.
Well, I think if you heard Tim Becker this morning talking about, what our goals are is integrated service delivery. And we've been doing a lot of that, where we have been sharing behavioral health and physical health and social, services related public health data. Together, we've got a master person index that we've utilized since 2001. So we have been utilizing that, and we've had our plans utilize it, but we need to get into the community. And so that's a part of being, prepared, being proactive, is to really move it to the community and for everybody to be able to share that information and know, again, with the population. So that's a lot of the initiatives that we have are to get into the community with the different types of, services across the continuum, whether it's, long-term care, it's behavioral health, it's physical health, it's, human services related. We need to be able to do that for everybody working together. Now, that's easy to say, the coordination of care, but as we're finding, they don't really know how to do that in many situations. Mm-hmm. And it's a whole culture that needs to be changed because we're still working in our silos. So even though we're sharing data, we're still sharing it and utilizing it in silos as opposed to actually, coordinating that care, truly coordinating that care.
So if I can just change the tact a little bit, what we've talked about so far fits very nicely with a big disaster, mm-hmm. or an expected disaster, or an untoward event that affects many, many people. As we've seen recently, some of the disasters, if I can label them as such, are much more subversive, and they really require, from a clinical perspective, I'll think about the changes that have occurred with some of the Zika virus things and that kind of stuff. It really requires a clinical sixth sense to say something's not right here. Rebecca, you would respond to that in a heartbeat, because something's not right here. It's just something that I can dig a little further, and then all of a sudden you start to see patterns and you start to see trends, and then you can mobilize the resources that we're talking about. I don't know if you've had that experience at all.
Yeah, I think we've had that experience. I think the other thing that I think of when I hear this conversation is to be ready is when these events happen, there's often multiple data sources ongoing at the time. And the replication of those resources is unfortunate because the resources are scarce. Mm-hmm. And so finding ways to quickly identify the data sources that are available and make them collated and integrated and then available both to public health professionals and as well to the community is really critical, because otherwise what we've seen both in Flint and in practice is we have 5 people getting good ideas and expending resources to develop answers to the same problems in silos, as opposed to putting the information together into an integrated way that can be shared. Since resources are so scarce, what we want to do is to answer the question once, not 5 times, and then come together with those answers.
And then hope you get the same.
And then hope we get the same answer.
So that's part of
right.
Right.
Yeah.
And I think, we've experienced that over and over again, that we find that they're going to multiple sources for the information, and maybe they don't know that
right.
someone else has given them information, and then you can have some conflict in that information, but also you may not have the whole picture. Because of the question that's coming in isn't saying exactly what you need to do. I mean, we can give you the numbers, but maybe that's not really what you want. Maybe you need more of the information, more of the clinical information that goes along with that. It's not just the number of individuals in this area, but what else about them do we know that would be helpful? And I think it goes along with, Marcus, you're mentioning about the preparedness and practicing this, and what do you do in these kinds of situations? Where do you go to ask for that information?
Yeah.
I learned recently, one of my sons is a fireman, and you think they know what to do in fire disasters. You think they do it all the time, they know what to do. He said what they do is they hear about houses that are going to be torn down or whatever, and the people call them up and say, go ahead and practice whatever you want to do there. Practice a fire, practice breaking in and doing whatever. So they practice, even though we think they're as honed and as trained as anyone else would be in an emergency response situation. So.
I want to, part of your question also was about communication and education. And I want to be honest and just share that I'm sort of a skeptic in that area. I was a public information officer for years, and so I know we know a lot. There's a lot that is known about how to communicate effectively and do it well, but we've got 3,000 different jurisdictions across the country, so there's going to be some folks in the upper tail that do it well and some in the lower tail that do it badly, and a big chunk in the middle that are mediocre. In reality, that's the way it's going to be. I think using the tools that we know that work effectively is what we do, but I also think there's a fundamental public policy problem, which is, of course, the media channels that we have are a public good, but we have largely privatized them. In today's world, communication is a private individual plugging into a private channel. So public service announcements are largely disappeared. The broadcasters on all types of media no longer have a responsibility to be fair and balanced or give the opposition time. All of those things have gone away. So I think the public voice is inherently muted. And I think HHS should see at the federal level public policy around public access to media as being something really important to public health and emergency communication. And they need to make that case that the pendulum has swung very far in one direction, and I think it needs to start to swing back. I don't know legislatively how you climb that mountain, but I think that's a real issue.
Yeah, it is. I think you're absolutely right, and you hit there are programs, there are CDCs known about their crisis communication, and once I even work with them. But also we cannot forget about our responders and following and registry and following their health over time. And I know that the ATSDR from CDC, Agency for the Toxic Registry, I'm not sure what is
Environmental.
Agency for, not sure. Anyway, they have a registry, and but it's costly. It's cost a big deal to make that registry for all people who are affected and follow up through time. So I would love to open this to audience, and do you have any input? What is your opinion about all this? We heard so many obstacles here, difficulties. What is your difficulties? Do you have anything positive to say about it? Yes. Oh, okay. I thought I'm going to walk.
You gonna walk? Coming.
Hello there. Hi, I'm Therese Hoyle, and I work in immunization information systems. And thank you, Marcus, for the PHII plug. So I work for them and for the state here. Here's my question. We prepare a lot with the immunization system for pandemic, influenza. One of the problems we worry about is we're interoperable. So we're hoping to get our data through electronic health records. If someone were to receive a vaccine in a preparedness effort, but how soon can we get the electronic health records to put those codes in to get them to us, because we need real-time data to report to HHS, and sometimes it takes months to get a new code in to an electronic health record system. How would that work?
So,
I don't think any of us are programmers at that point. So part of it is a very simple answer that right now, and I don't know if Mr. Wagenknecht is still here or not, but the pharmacy industry has barcodes so that when administration happens, it immediately can be scanned and put into the electronic record, except for immunizations. There is not a universal barcoding system for immunizations. We've had some of our own health systems, I'll call it a skunkworks effort, where they've done their own partnership with the hospital pharmacy and created barcodes, but it does have to be segregated, as you know, by vaccines that are supplied by the state versus those that are purchased commercially. And so they've gone ahead and created their own solutions. Unfortunately, it's not a universal effort. So that would be another way to answer your immunization question, so that mass immunizations could be tracked and trended. If we can get some universal barcoding, then we might be able to get the new ones coded faster.
And I wonder, is this partly also a federal IT policy governance issue? Is there something about the relationship between the vendor community and the public health community that we need to work on to make this go faster? I'd love to hear your answer, Therese.
We are working with the Electronic Health Record Trade Organization, to help them on the importance of this. The problem, and I think you're right about barcodes, we are doing better with the NDC code for immunizations. If we could get those, and we have all the current ones in our systems, we could get that data. But sometimes it takes a while for them. They still have to plug the NDC code into the EHR. So it's still an issue of getting the vendor to get that code in a timely fashion. So when flu season happens now in June, we start coding in June. August, you can get vaccine. The EHRs aren't ready. The patients are being vaccinated. The data can't come to us because it doesn't have the right code. So our worry is we don't want paper. The last thing we want is the health departments to track on paper or a private provider. So we do sell this to the trade commissions, but could we have health system buy-in, HIMSS buy-in? I mean, where could we leverage, or HHS, to say this has to happen within 10 days of a pandemic, and everybody's ready to send data? When the vaccine arrives, you are ready. That's the question. But thank you, Marcus.
Well, we'll discuss it at the next JFIT meeting.
Yeah, and not to get too much in the weeds, if it is a centralized cloud vendor, it's a lot easier
Yeah.
than if, yeah, otherwise it's, I own my own EHR, you're asking me to put it in, right? So,
Yeah. How do you update all the implementations?
yeah.
anyone else? Any experience? Good and bad?
So I need to step in as a representative of a physician organization in Michigan. Most of the POs in Michigan have very robust patient registries that actually capture all of the immunizations and all of the prevention and a lot of the other items that you are currently discussing. So maybe what we should be doing is reaching out to the POs in the state to work more closely with those of you at the state level and with MiHIN to capture this data. The other side of the coin is we're looking at first responders, so we're looking at the fire department, we're looking at the National Guard. A lot of what's really in place already in Michigan, again, the healthcare community is being somewhat pushed aside and not engaged in that discussion, and really including them in this discussion would be very beneficial. But I do have a question for those of you in the Flint environment. How did that physician run her trend report to identify the lead levels rising in that very short period of time when she was able to ascertain changes in lead levels? How did that happen? What registry did she use? And what EHR did she have in place?
Don't know the answer to that.
I do, and I don't have an official answer to that, but my general understanding of how that report was run was Hurley Hospital is the central public hospital for Flint. It sees the vast majority of the population and almost all of the children in Flint for emergency care and a lot for pediatric care as well. We know that most of the children in Flint, although some have a medical home, we know from our own data and certainly from my data over the past years that children in Flint on average are seen in the emergency department at Hurley Hospital 4 times a year for an assortment of reasons from primary care to not primary care. So the Hurley Hospital, my understanding, and this is from what I know and not an official report, but my understanding is that she pulled the hospital records on the children during the time from her practice, essentially. It was a retrospective chart review of the hospital data, so the data was based at the hospital.
So does MiHIN not follow lead levels? So if MiHIN follows lead levels, would they not have been able to identify that in their own trend report?
Please. Someone get his exercise.
That is a great question. MiHIN does display lead levels. We don't store them. So we pull the data from the data warehouse, and then we display it to the provider. So we don't have the analysis because we don't have the data. So, but Cynthia, could the warehouse look at it? I never thought about that.
Yes, the data warehouse does have the blood lead results in the data warehouse that analytics can be done against. But as you mentioned, we do display them in MiHIN, and maybe you're not seeing the whole population, but you are seeing all the blood lead levels when the physician goes in. So they can see if they've had the test and then if they've had multiple tests, regardless of where they were done. And so that is always available there for, the immediate response to that at the physician's office and the emergency department and so forth.
And I'm maybe getting a little bit far afield, but I've spoken to Sue Moran about this, and she told me candidly, and the CLIP database also is not a surveillance system. It wasn't set up. They're not looking every week to see if there are lead hotspots and so on. So the data's there. So part of what they've done is now they're hiring more EPIs, and they're going to try to figure out which of their data systems really could be upgraded and used as real-time surveillance systems.
Yep. Right.
Yeah, that's what I was going to say. It's a surveillance activity, not a
Right.
scoring and reporting
That's right.
activity.
Yeah.
So, yeah.
To the panelists, and particularly Dr. Cheatham, there's been a lot of discussion about integration and interoperability across MMIS systems. I hear that there's also a public health platform, for example, that will also help establish and encourage exchange across the spectrum of care. I was wondering if you and other panelists could address some of the newest thinking, as you are thought leaders in this realm, of what's taking place and how this pushes us forward in Michigan and beyond to support greater cooperation, coordination, and interoperability across the spectrum of care.
Well, that was so well said. I think all I need to do is say yes. There's been a lot of work done by the Council of State and Territorial Epidemiologists, Association of Public Health Labs, ASTO, with CDC funding to begin to work on electronic case reporting. And so again, another conversation that I had with Jim Collins, who's seated right down here, many, many years ago. Why do we need to use electronic health records to do reporting? Don't the doctors report? They're required to do it in the law. And I think Jim said, we think we know like less than half the disease that's actually out there. So the idea is that an electronic health record will have trigger codes in it. He's denying that he said it. They will have electronic it will have trigger codes in it, and it will know when a practitioner is entering something that could be notifiable. It might pop up a box and say, this sounds like this could be tuberculosis. It's a reportable disease. Would you like me to report that to public health for you right now? And the public health community platform has this reportable condition knowledge management system in it. It will receive the report, figure out what the disease is, what the jurisdiction is, and send the message to public health addressing the problem of underreporting of disease. So then if you think about emerging problems, lead's not a reportable disease, although it's reportable to the state. We could start having lead be reported in that manner. Zika virus, when it starts to spread across the South, we can start tracking and being on top of Zika. I want to be perfectly honest, there's just 2 pilot projects that are operational, Illinois and Utah. Michigan's still, I think, a ways away from doing this. So we're in the early days, and we also don't know anything about how the back end of this would work, where we would build our panel, our cohort of people, and how we would follow up with them, especially since every disease business process, how you follow up with people, it's always different. So there's this whole issue of how do we use one reporting system to do 70 different things, but Jim's going to tell us.
No, this is on?
Yes.
Yep. Okay. So a couple quick, that's great, Marcus. And Marcus is very much on top of the informatics stuff. Don't let him fool you. I've been sitting on the interim executive committee for this public health community platform for a while now. And one of the big pluses, I think, for the idea of a centralized platform that I don't know that you touched on is to have shared services. Just from the perspective of a vendor, of an EHR vendor, would you rather negotiate with one platform or 50 jurisdictions to do your reporting, right? Trigger codes have become a little more complicated as we move along because of the kind of inconsistent use of these electronic health records, but we're making a lot of progress. And the Michigan pilot, which is a little different than what's going on in Illinois and Utah, because what we really plan to do in Michigan is leverage the state's HIE infrastructure, which is really strong here, and to try to work between the HIEs and the platform. So it's the whole thing about the many to the one, and it really makes the project more manageable and I think more productive and more doable to leverage these centralized focus. So leverage MiHIN in the interaction with the platform. Leverage a platform versus negotiating with every state, right? And then have that interaction take place, and then MiHIN maintains a single portal to the state, and so that the feeds are manageable and it goes down to the provider level. Now, one of the things that was brought up earlier is what drives this. So we have the meaningful use driver, right? So this electronic case reporting should be in meaningful use in 2018. It's going to be in there as a menu item. But what really drives it, I think, is providers asking their vendors to put this in their systems, to make it doable. What they tell us used to be, well, it's all money. No, it's really what their clients want. They want to keep their clients happy. And so if their clients demand certain things, they demand the functionality to do electronic case reporting, they demand the functionality to incorporate trigger codes into their systems, then they're more likely to put it in there. So.
And I think, you know, we've talked a lot about barriers, and, you know, there are a lot of barriers, but there's a lot of really good stuff that's going on and is being shared. And I think the whole infrastructure that we developed within the state of Michigan works. And we've been able to prove that. And I know when the Flint situation came up, we were asked, how are you utilizing this HIE infrastructure? And it's like, we're set to be able to do that, but if we're not utilizing it, I mean, the capabilities are there, but we have to utilize it. And as we're saying, to try to streamline, and it's not just about meaningful use and checking off that mark for meaningful use. It's what does that do to help us to manage the care? Because if you just look at it as meaningful use, I mean, it's always a good one for us to say, oh, you have to do it for meaningful use. But then the whole mindset is going to be, we're just doing that to check off. Instead of, here's how this is going to help us, it gives us more of those other ideas of how you can utilize this system to really manage care better.
And one other quick point, if I could, is that if we can do this for communicable diseases, we can do it for chronic diseases, and we can do it for emergency management. We're already using this technology to do syndromic surveillance. Messaging from our emergency department and urgent care facilities is flowing through MiHIN to the state of Michigan, so that the process is in place. what these electronic health records promise is a much richer message. It gives public health a much better basis upon which to base their response and to do their interviews. And in terms of blood lead levels in particular, we've been doing electronic laboratory reporting for blood lead levels for some time from a number of reporting laboratories. So we have that in place. We can leverage the same technology to get more in place.
Hi, this is Jim Brule from Allscripts, one of those terrible vendors. And we're really excited about being able to contribute to that. I'm over here. Very excited about our engagement with that. We're very active in the Zika virus response as well. One of the challenges we see, just to make things a little more complicated, is alert fatigue. You know, the more and more things that we think about asking clinicians to report on, the less and less they use the system. Because it is so, and having been a clinician myself, I can tell you, it's deadening to have to, you know, cycle through all these things. So the design of how, and I think it has to be a collaborative design. It's not something that we do by ourselves. The collaborative design of how do we make this clinically relevant, delivering data that's actually valuable and other kinds of value is beyond a vendor's ability. It requires a vendor's ability, but it requires others as well. And I just want to encourage that kind of collaborative design.
Yes, and we've had, you know, I spoke at a conference and there was, you know, we were talking about all the capabilities. And somebody with an FQHC said, but my vendor said that we don't have that. Yeah. They had a certified system that's supposed to have that capability, but they haven't implemented it within the office, within the FQHC. So that is part of the problem, and as Jim's mentioning, that those capabilities are there with the certified systems, but it doesn't mean that they've set that up and have the workflow. Right. You know, that's a whole change in the workflow, and as we've used MC to try to help with not just implement the EHR, but the whole workflow, and then maybe it's somebody else who's looking at that information and preparing the physician when they are seeing the individual, but it's available to them.
Right.
Go ahead.
I would also say, to your point, so on the provider end of making it doable for the provider also means providing that background information as a synthesis to the provider to make them more interested in actually utilizing the system fully. And whether that means having someone else enter the many details that go into the EHR or not, but like when I think of PDMP or opioid data, and the fact that some of that is available now in an assortment of EHR systems, it's not providing it in a synthesized way that would make it informative to the provider beyond the raw data is where you will get more buy-in on the provider end.
Are you trying to gong us off?
I was going to make a comment, but I see a hook. So.
If you have one more thing you want to add,
No,
I don't
I'm
want to
good.
interrupt.
Well, I do.
Go
I
ahead.
have one more thing that really keeps me up at night, and it was something that happened to me the first week that I was a health officer. My predecessor had worked for 2 years with regional hospitals on a community health assessment and improvement plan. They had the great community meeting at the end where everybody blessed the plan and they were to go forward. And so afterwards, the hospital CEOs and the health officer huddled, and the health officer said, so hospitals, how much are you in for? How much are you going to, and what we learned from that is we should have been working with the Trinity Hospital. Because they said, we're not in, and they walked. And so I called one of them, had an appointment, met with her, and I said, why aren't you supporting the plan? And she said, because I feel like you're asking me to pay you to do your job. Your job is to do community-based prevention. And what I don't know, if you can show me that you do a community-based smoking cessation activity and people actually quit smoking, and especially if it's actually some of the people I serve who quit smoking, I'll give you lots of money. I'll give you, we'll figure out how many readmissions and emergency room visits we've avoided, and I'll give you half of that so you can keep doing this. And what I learned from that and what I see happening now with the state innovation model is in order to make our community health innovation regions and accountable systems of care sustainable over time, we have to be able to demonstrate that level of return on investment. And I'm worried that we're not building that piece and that we need to anticipate that problem, figure out what that's going to look like and start building that. I think that's a huge challenge we'll face in the next few years.
Dr. Forsley, did you have one more thing?
Oh,
you
no,
wanted to
actually,
say?
I was just going to
Okay.
mention to Marcus that come talk to us, because as you might know, Trinity is actually working on innovation,
Yeah.
especially in the quit smoking area.
Oh, yeah.
Great. Well, thank you very much, panel. We appreciate all of your insights, and thank all of you for participating in this. It's really been very special.